The fluorescent lights of the VA Medical Center cafeteria buzzed overhead like angry wasps, casting harsh shadows across Dr. Sarah Chen's weathered hands as she reached for her military ID. The plastic card trembled slightly, not from nerves but from the phantom pain that still visited her left shoulder on humid days like this one. Around her, the lunch rush created a symphony of clinking trays, muffled conversations, and the occasional burst of laughter from a table of young veterans comparing war stories they were still learning how to tell. Preparing and narrating this type of story took us long efforts and hard work, so if you are enjoying the story, please consider subscribing to our channel. "Ma'am, I'm going to need to see some additional identification," the security guard said, his voice carrying the particular blend of authority and uncertainty that came with questioning someone you weren't quite sure you should be questioning. His name tag read Martinez, and Sarah could see the conflict playing out behind his eyes, the weight of protocol versus the nagging sense that something wasn't adding up the way his training manual had promised it would. Sarah's fingers found the raised scar tissue along her collarbone, a nervous habit she'd developed during the long months of recovery. The cafeteria seemed to pulse around her, conversations growing muffled as if she were underwater. She could feel the eyes of other diners turning toward their table, some curious, others sympathetic, a few already reaching for their phones with the reflexive motion of a generation raised on viral moments and social justice hashtags. "This is my military ID," she said quietly, her voice carrying the measured tone she'd learned to use when dealing with situations that required both patience and precision. "I'm Dr. Sarah Chen, Lieutenant Colonel, Army Medical Corps. I'm here for the monthly Veteran Healthcare Symposium." Martinez shifted his weight from one foot to the other, his radio crackling with distant chatter from other parts of the medical complex. Behind him, his supervisor, an older man with graying temples and the kind of bureaucratic confidence that came from years of following procedures without questioning their purpose, approached with the deliberate steps of someone who believed that most problems could be solved by applying the right regulation with sufficient force. "The issue, ma'am," Martinez continued, glancing back at his supervisor for reassurance, "is that this doesn't look like you." He held up the ID card, comparing the photograph to Sarah's face with the methodical attention of someone who had been trained to spot discrepancies but perhaps not to understand their context. The photograph showed a different version of Sarah, younger, fuller-faced, with both eyes intact and unmarked by the spider web of surgical scars that now traced delicate patterns across the left side of her face. Her hair in the photo was regulation length and untouched by the premature silver that stress and trauma had woven through the black strands. Most notably, the woman in the photograph had been captured before the roadside bomb outside Kandahar had stolen her left eye and replaced it with a prosthetic that, while expertly crafted, would never quite match the warm brown of its surviving partner. "People change," Sarah said, her remaining eye meeting Martinez's gaze with the steady intensity of someone who had learned to see clearly with half the vision she'd been born with, especially after combat. The word combat seemed to hang in the air like smoke, drawing attention from nearby tables where other veterans sat with their own collections of visible and invisible wounds. Sarah recognized the look that passed between them, a mixture of solidarity and curiosity, the unspoken question of which war, which deployment, which particular brand of hell had carved its signature into her features. At a corner table, a man in his early 30s looked up from his untouched sandwich. His name was Marcus Rodriguez, though Sarah didn't know that yet, and the tribal tattoo visible beneath his rolled-up sleeves bore the trident that marked him as a Navy SEAL. He had been trying to work up the appetite to eat, fighting the familiar battle with the medications that kept his PTSD symptoms manageable, but had turned his relationship with hunger into something complicated and unpredictable. The raised voices near the security checkpoint had pulled his attention away from the internal struggle, and something about the woman's posture, the particular way she held herself that spoke of military bearing softened by suffering, made him set down his coffee and pay closer attention. The supervisor had reached Martinez now, and Sarah could see the bureaucratic machinery beginning to turn in earnest. "Ma'am, we're going to need you to come with us to the security office while we verify your credentials," the older man said, his tone suggesting that this was not a request so much as a politely worded command. Sarah's hand moved instinctively to the small leather journal she always carried, a habit from her deployment days when documenting everything had been the difference between life and death for her patients. The journal contained not just her medical notes and appointment schedules, but also the letters from grateful families, the photographs of soldiers whose lives she had saved, and the carefully preserved thank you cards that arrived months or sometimes years after she had sewn their bodies back together in field hospitals, where the air tasted of dust and antiseptic, and the constant possibility of mortar fire. "I understand you're following protocol," Sarah said, her voice remaining level despite the familiar tightness in her chest that came whenever authority figures began to doubt her credibility. "But I have a presentation to give in 20 minutes to a room full of veteran healthcare providers about trauma surgery techniques. These are techniques I developed while serving 3 combat deployments as a forward surgical team leader." The mention of her presentation seemed to catch the attention of several people at nearby tables, including Dr. Amanda Foster, a VA psychiatrist who had been looking forward to Sarah's talk on the psychological aspects of battlefield medicine. Amanda had read Sarah's published papers on treating combat trauma and had driven 2 hours to attend this symposium specifically to hear her speak. Now she found herself witnessing what appeared to be a security incident involving her afternoon's keynote speaker. "The problem," the supervisor continued, his voice taking on the patronizing tone that suggested he had dealt with many people who claimed to be things they were not, "is that this identification shows signs of potential tampering, and the photograph doesn't provide a clear match to your current appearance." Sarah felt the familiar heat of frustration building behind her sternum, not anger exactly, but the weary recognition that she was about to be asked to prove her own existence once again. It was a sensation she had grown accustomed to since returning stateside, the constant requirement to validate her service, her expertise, her right to occupy spaces that others took for granted. The prosthetic eye, the surgical scars, the premature aging that came with having seen too much too young, these had become not just reminders of her service, but obstacles to having that service recognized and respected. "My identification is legitimate," she said, reaching into her jacket pocket to retrieve her phone. "I can call my commanding officer. I can show you my medical license. I can provide you with documentation of my current appointment here at the VA. What I cannot do is change the fact that war changes people in ways that don't always fit neatly into your recognition protocols." The cafeteria had grown quieter now, conversations tapering off as more people became aware of the drama unfolding near the security desk. Sarah could feel the weight of their attention, some sympathetic, others merely curious about the disruption to their lunch routine. She recognized several faces from previous medical conferences, colleagues who knew her work if not her personal story, and she could see the recognition dawning in their expressions as they put together the pieces of what they were witnessing. Marcus Rodriguez had stood up from his corner table, his untouched sandwich forgotten as he moved closer to the security checkpoint. Something about the woman's bearing, the way she held herself despite the obvious stress of the situation, reminded him of the medical officers he had worked with downrange. There was a particular quality that combat medics and surgeons developed, a combination of compassion and steel that came from having to maintain clinical precision while people were shooting at you. "The issue," Martinez was saying, clearly uncomfortable with the attention their interaction was drawing, "is that we've had problems recently with people using fake military IDs to access veteran benefits and services. We have to be thorough in our verification process." Sarah nodded, understanding the logic even as she felt the familiar frustration of being painted with the brush of other people's deceptions. "I appreciate that you're trying to protect resources for legitimate veterans," she said, "but I am a legitimate veteran, and I have documentation to prove it. More importantly, I have a room full of medical professionals waiting to learn techniques that could save lives." Dr. Foster had approached the group now, her psychiatrist's training making her acutely aware of the stress signals radiating from all parties involved. "Excuse me," she said, addressing the security supervisor, "but Dr. Chen is our keynote speaker for this afternoon's trauma surgery symposium." Her credentials were verified weeks ago, when she was invited to present. The supervisor turned to Dr. Foster with the polite but dismissive attention he reserved for people who thought they were helping but were actually complicating his job. "Ma'am, I appreciate your input, but security verification is a separate process from event planning. We have protocols to follow." Sarah felt the moment stretching like a rubber band about to snap. Around her, she could sense the complex dynamics of institutional bureaucracy, professional solidarity, and the particular vulnerability that came with having to constantly prove that your service and sacrifice had been real. The prosthetic eye saw nothing, but her remaining eye caught every detail. The way Martinez's hand rested near his radio, the growing cluster of onlookers, the mix of sympathy and secondhand embarrassment on the faces of her colleagues. It was then that Marcus Rodriguez stepped forward, his movement cutting through the tension like a blade through silk. "Excuse me," he said, his voice carrying the particular authority that came not from rank or position but from absolute certainty. "I couldn't help but overhear, and I think there might be some confusion here." The supervisor turned toward Marcus with the weary expression of someone whose afternoon was becoming more complicated by the minute. "Sir, this is a security matter. I'm going to have to ask you to return to your table." Marcus looked directly at Sarah, his eyes moving with practiced efficiency across the surgical scars that mapped the left side of her face. Years of working with combat medics had taught him to read the stories written in scar tissue, and what he saw in Sarah's face was a narrative he recognized with absolute clarity. "Those scars," he said quietly, his voice pitched for Sarah's ears but carrying clearly in the hushed cafeteria, "are from emergency surgery performed under combat conditions. The pattern suggests treatment for shrapnel wounds to the orbital socket and temporal region, probably from an IED blast. The surgical technique shows field hospital work, precise but done under time pressure and resource constraints." The cafeteria had gone completely silent now. Sarah felt her breath catch in her throat as Marcus continued, his voice taking on the tone of someone delivering medical testimony. "The scarring on her hands is consistent with defensive wounds from handling explosive damaged patients. You get those kinds of cuts from working with metal fragments and damaged equipment while trying to save lives under fire." Marcus looked directly at the supervisor, his voice carrying absolute conviction. "This woman is not only a legitimate veteran, she's a combat surgeon who operated in forward positions under enemy fire." Sarah felt tears threatening behind her remaining eye, not from sadness but from the profound relief of being seen and recognized by someone who understood the stories her scars told. Marcus's recognition wasn't just professional, it was the acknowledgement of a shared world that most people could never truly comprehend. The supervisor looked between Marcus and Sarah, his bureaucratic certainty beginning to waver in the face of specific medical details that would be impossible to fake. Dr. Foster had moved closer, her professional interest clearly piqued by Marcus's detailed assessment of Sarah's surgical history. "Sir," Martinez said quietly to his supervisor, "maybe we should." But the supervisor was already reaching for his radio, his voice carrying the clipped tones of someone who had realized that his afternoon had just become much more complicated than a simple ID verification. As he began to call for additional verification procedures, Sarah caught Marcus's eye and saw something there that transcended the immediate crisis. The recognition that passed between people who had served in the same hidden world of combat medicine, where healing and harm existed in constant, terrible proximity. The question that hung in the air now was not whether Sarah's ID was legitimate, but how a system designed to serve veterans could fail so completely to recognize the very people it was meant to protect. And as the crowd of onlookers continued to grow, it became clear that this moment would extend far beyond a simple security verification, rippling outward into questions about recognition, respect, and the invisible wounds that service members carry long after they return home. The fluorescent lights continued to buzz overhead, but the cafeteria no longer felt like a simple dining space. It had become a stage where larger questions about service, sacrifice, and recognition were about to be examined under the harsh light of public attention. The security office smelled of industrial carpet and the kind of coffee that had been sitting too long in a pot that hadn't been properly cleaned in weeks. Sarah sat in an uncomfortable plastic chair, her military ID and medical license spread across the supervisor's desk like evidence in a criminal case, while the institutional machinery of verification ground slowly forward around her. Through the thin walls, she could hear the muffled sounds of the medical center continuing its daily operations, people seeking help, professionals providing care, the endless rhythm of healing that had become the soundtrack of her post-military life. Marcus Rodriguez had been allowed to remain as a witness, his status as a decorated Navy SEAL apparently carrying enough weight to override normal protocol restrictions. He sat across from Sarah, his presence both comforting and slightly unsettling in the way that recognition from a fellow warrior always was. It meant being seen completely, both the strength and the damage. "Dr. Chen," the supervisor said, reading from his computer screen with the mechanical precision of someone working through a checklist. According to our initial verification, your service record shows 3 deployments to Afghanistan between 2018 and 2022, with a specialization in forward surgical operations. You were awarded the Bronze Star Medal with Combat V for valor under fire during a complex surgical operation that saved the lives of 8 coalition soldiers. Sarah nodded, her fingers automatically finding the small bronze star pin she wore on her jacket lapel, not from vanity, but as a reminder of the weight that came with surviving when others hadn't. That's correct. The operation took place at Forward Operating Base Chapman in October 2021. We were treating casualties from a convoy that had hit an improvised explosive device when the base came under mortar attack. The supervisor looked up from his screen, his expression showing the first signs of uncertainty about his initial assessment. The record also shows that you were wounded in action during that same deployment and medically evacuated to Landstuhl Regional Medical Center in Germany. February 15, 2022, Sarah said quietly. Roadside bomb during a medical evacuation convoy. I was riding with a patient we were transporting to a higher level of care. She touched the scar tissue around her left eye socket, a gesture that had become unconscious over the years. I lost my left eye, suffered traumatic brain injury, and had multiple surgeries to repair facial fractures. I spent 4 months at Walter Reed recovering before being medically retired. Marcus leaned forward slightly, his voice carrying the particular gentleness that combat veterans used when discussing each other's wounds. The surgical scars show expert reconstruction work, military medicine at its finest. They kept your function and did their best with cosmetics under the circumstances. Sarah managed a small smile, the first genuine expression of warmth she had shown since the confrontation in the cafeteria began. Dr. Rebecca Martinez at Walter Reed. She's a miracle worker. Told me that if I was going to insist on keeping my medical career, she was going to make sure I had a face that wouldn't scare my patients. The mention of continuing her medical career seemed to catch the supervisor's attention. You're still practicing medicine? I'm the chief of trauma surgery at Presbyterian Medical Center, Sarah replied, noting the way his expression shifted as the implications of his earlier actions began to dawn on him. I also serve as a consulting surgeon for the VA's Combat Trauma Recovery Program and teach advanced surgical techniques at the medical school. Today's presentation was on managing penetrating trauma injuries in resource-limited environments, techniques I developed during my deployments. Dr. Amanda Foster appeared in the doorway of the security office, her professional credentials apparently sufficient to gain her access to the ongoing verification process. I'm sorry to interrupt, she said, addressing the supervisor, but Dr. Chen's presentation is scheduled to begin in 10 minutes, and we have over 100 medical professionals waiting to hear her speak. The supervisor looked between his computer screen, Sarah's identification documents, and the growing evidence that he had significantly misjudged the situation. Dr. Foster, I understand the inconvenience, but we have protocols. What you have, Dr. Foster interrupted with the calm authority of someone accustomed to dealing with institutional dysfunction, is a decorated combat veteran and respected surgeon being detained because her appearance doesn't match your expectations of what a military officer should look like. Marcus stood up, his movement drawing attention from everyone in the small office. Permission to speak freely? He said, though his tone suggested he was going to speak regardless of permission granted. The supervisor nodded, perhaps sensing that the situation had moved beyond his ability to control through normal administrative channels. I served 4 deployments with Special Operations Command, Marcus began, his voice carrying the weight of someone who had seen the full spectrum of military service. I worked with medical personnel in every theater: Army, Navy, Air Force, Marines. I've seen combat surgeons work under direct fire, treating casualties while mortars were landing 50 meters away. I've watched them make life-and-death decisions with steady hands while buildings were collapsing around them. He looked directly at Sarah, his expression showing the particular respect that warriors reserved for those who had chosen to heal rather than harm in the midst of war. This woman has the scars of someone who put herself in harm's way to save others. The pattern of injuries, the surgical reconstruction, the way she carries herself, everything about her story is consistent with forward combat medical service. More than that, it's consistent with exceptional service under extraordinary circumstances. Sarah felt the familiar tightness in her chest that came whenever someone recognized not just her service, but the cost of that service. The medical retirement, the long months of reconstruction surgery, the struggle to rebuild not just her face but her identity as a surgeon. It was a story she had learned to tell in clinical terms, but Marcus was speaking about it in the language of shared experience. The Bronze Star with Combat V isn't awarded lightly, Marcus continued, his voice taking on the tone of someone delivering testimony under oath. It requires not just being wounded in combat, but performing acts of valor while under enemy fire. For a medical officer to receive that decoration typically means they stayed with wounded soldiers when the tactically sound decision would have been to evacuate. The supervisor was scrolling through his computer screen now, his expression showing the growing realization that he was dealing with someone whose service record was not only legitimate, but exceptional. Dr. Chen, I'm seeing here that you were also awarded the Purple Heart, the Combat Medical Badge, and the Meritorious Service Medal. The Meritorious Service Medal was for developing new triage protocols that reduced battlefield mortality rates by 12%, Sarah said quietly. The techniques I developed are now taught at every military medical training facility. Today's presentation includes updated versions of those protocols adapted for civilian trauma centers. Dr. Foster checked her watch, her expression showing increasing concern about the delayed presentation. Dr. Chen, we have medical professionals who have traveled from across the region to hear you speak. Some of them are implementing trauma programs in their own hospitals based on your published research. Sarah stood up, her movement careful and deliberate in the way of someone who had learned to compensate for altered depth perception. I understand that security protocols are important, she said, addressing the supervisor with the measured tone she used when trying to de-escalate tense situations. But I hope you can understand that being questioned about the legitimacy of my service feels like being asked to prove that my wounds are real. The supervisor looked down at the documentation spread across his desk, the military ID, the medical license, the computer screen showing a service record that read like a testament to dedication under fire. When he looked back up at Sarah, his expression had changed completely. Dr. Chen, I owe you an apology, he said, his voice carrying the particular weight of someone who had realized the magnitude of their mistake. Your identification is clearly legitimate, and your service record speaks for itself. I should have recognized that injuries sustained in combat could significantly alter someone's appearance. Sarah nodded, accepting the apology with the grace of someone who had learned that anger was a luxury she couldn't afford if she wanted to continue working within systems that didn't always understand her experience. I appreciate that. I know you were trying to protect resources for legitimate veterans. That's important work. Marcus stepped forward, his expression showing the particular solidarity that existed between combat veterans who had learned to recognize each other across service branches and specialties. Dr. Chen, if you don't mind me asking, what unit were you with? Combat Support Hospital, 86 Medical Brigade, Sarah replied. We provided surgical support for Special Operations Command missions throughout Regional Command East. Marcus's expression shifted, showing a recognition that went beyond professional courtesy. I know that unit. You guys patched up half my team after a mission went sideways near Jalalabad in 2021. 3 of my guys would have died without that level of surgical expertise in a forward position. Sarah felt the familiar mix of pride and sadness that came with these recognitions. Every successful surgery in a combat zone represented lives saved. But it also represented the broader tragedy of young people being broken by war and the medical professionals who spent their careers trying to put them back together. That's why I continue to teach, she said, her voice carrying the conviction that had driven her through years of painful reconstruction surgery and professional rehabilitation. The techniques we developed in combat zones can save lives in civilian trauma centers. Car accidents, industrial injuries, domestic violence. The principles of damage control surgery are the same whether the wounds come from an IED or a drunk driver. Dr. Foster had been listening to the exchange with the attention of someone who understood both the medical and psychological implications of what was being discussed. Dr. Chen, your research on the psychological impact of providing medical care under combat conditions has changed how we approach trauma therapy for medical personnel. Your work has helped us understand that doctors and nurses can suffer from combat PTSD just as much as infantry soldiers. Sarah nodded, thinking of the nights when she still woke up hearing the sound of incoming mortars, her hands automatically reaching for surgical instruments that weren't there. People think that because we were saving lives instead of taking them, we should be immune to psychological trauma. But when you're operating on someone while people are shooting at the building you're in, when you're trying to save a 19-year-old's leg while his friends are bleeding out on the table next to him, that leaves its own kind of scars. The supervisor had been listening to this exchange with growing awareness of the complexity of the situation he had created. Dr. Chen, again, I apologize for the delay and the inconvenience. Is there anything we can do to help you get to your presentation? Sarah gathered her identification documents, sliding them back into her jacket pocket with movements that spoke of long practice with managing official paperwork. Just help me understand how we can prevent this from happening to other veterans. The prosthetic eye, the surgical scars, these are common injuries for combat veterans. Your staff should be trained to recognize that war changes people in visible ways. Marcus stood as well, his expression showing the particular respect that came from recognizing not just courage under fire, but the continued courage required to rebuild a life after combat. Dr. Chen, would you mind if I attended your presentation? I'm always interested in learning about advances in combat medicine. Sarah looked at Marcus, seeing in his face the echo of every special operations soldier she had treated during her deployments. Young men who carried themselves with deadly competence, but who could show remarkable gentleness when dealing with wounded comrades. Of course. Though I should warn you, some of the surgical footage can be pretty graphic. Marcus smiled, the expression transforming his face from its default military seriousness into something warmer and more accessible. Ma'am, I've been on the receiving end of combat surgery more times than I care to count. I think I can handle the educational version. As they prepared to leave the security office, Sarah reflected on the strange turns that had brought her to this moment, from the operating rooms of forward surgical teams to the bureaucratic tangles of veteran healthcare, from the life and death decisions of combat medicine to the equally important but different challenges of teaching others to save lives. The path had been marked by loss and pain, but also by the profound satisfaction of work that mattered. The fluorescent lights of the medical center corridor seemed less harsh as they walked toward the conference room where her colleagues were waiting. Behind them, the security supervisor was already on the phone, presumably beginning the process of reviewing protocols that had failed to account for the visible wounds that combat veterans carried home with them. Sarah touched the leather journal in her jacket pocket, feeling the familiar weight of the letters and photographs from soldiers whose lives she had saved. Today's presentation would add new knowledge to the long chain of medical expertise that stretched from battlefield hospitals to civilian trauma centers, carrying forward the hard-won lessons of combat medicine into a world that desperately needed to understand both the techniques and the human cost of healing under fire. The conference room buzzed with the particular energy of medical professionals gathering to share knowledge that could mean the difference between life and death in emergency situations. Dr. Sarah Chen stood at the front of the room, connecting her laptop to the projection system while over 100 trauma surgeons, emergency physicians, and combat medics took their seats. The afternoon light streaming through the windows cast long shadows across the assembled crowd, and Sarah could see faces she recognized from medical journals, colleagues from previous conferences, and younger doctors whose eager expressions reminded her of herself at the beginning of her career. Marcus Rodriguez had taken a seat in the back row, his presence both comforting and slightly surreal after the events in the cafeteria. Sarah had given presentations to military audiences before, but having a special operations veteran in a room full of civilian medical personnel added a dimension she hadn't quite anticipated. His understanding of combat medicine came from the receiving end, the perspective of someone who had depended on surgical expertise while bleeding on a field hospital table. "Good afternoon, everyone," Sarah began, her voice carrying clearly across the room. "I'm Dr. Sarah Chen, and for the next hour we're going to discuss advanced trauma surgery techniques developed in combat zones and their applications in civilian emergency medicine." The first slide of her presentation appeared on the screen, a photograph of a forward surgical team operating in a reinforced bunker in Afghanistan, the medical personnel wearing body armor over their surgical scrubs while they worked to save the life of a wounded soldier. The image captured the particular intensity of combat medicine, the combination of clinical precision and environmental chaos that had defined Sarah's military service. "Combat medicine operates under constraints that most civilian facilities never encounter," Sarah continued, advancing to the next slide. "Limited resources, hostile environments, and the constant pressure of time mean that we had to develop techniques that prioritized speed and effectiveness over ideal conditions." Dr. Amanda Foster, sitting in the third row, raised her hand. "Dr. Chen, before we begin, I think many of us would benefit from understanding your specific experience in combat zones. Could you give us some background on your deployments?" Sarah had been expecting this question, though it still required her to shift mental gears from clinical instructor to combat veterans sharing personal experience. I served 3 deployments to Afghanistan between 2018 and 2022 with the 86th Medical Brigade. My team provided surgical support for Special Operations Command missions throughout Regional Command East. We operated forward surgical teams that could be deployed rapidly to provide damage control surgery in locations where evacuation to higher levels of care might take hours or days. A young resident in the front row looked up from his notepad. What does damage control surgery mean in practical terms? Sarah clicked to the next slide, which showed a diagram of surgical procedures, prioritized by urgency and resource availability. In civilian medicine, we have the luxury of comprehensive treatment. In combat zones, we often had to make decisions about which procedures were essential for immediate survival versus which could wait for evacuation to better-equipped hospitals. The goal was to keep soldiers alive long enough to get them to Germany or the United States for definitive care. Marcus shifted in his seat, recognizing the clinical description of procedures that had very personal meaning for him. He remembered waking up in a hospital in Germany, his left leg held together with external fixators and titanium hardware, being told that the surgeon at the forward operating base had saved his leg, but that months of reconstruction surgery lay ahead. The abstract concepts Sarah was describing had been the reality of his survival. The techniques we developed, Sarah continued, focused on rapid hemorrhage control, abbreviated surgical procedures, and creative solutions for working with limited equipment. Many of these techniques have direct applications in civilian trauma centers, especially in rural hospitals or during mass casualty events. Dr. James Morrison, the chief of emergency medicine at a Level 1 trauma center, leaned forward with obvious interest. Can you give us specific examples of how combat-developed techniques have improved civilian outcomes? Sarah advanced to a slide showing before and after mortality statistics from several urban trauma centers that had implemented combat-derived protocols. The most significant improvement has been in our approach to hemorrhagic shock. Combat medicine taught us that aggressive early blood product transfusion could prevent the coagulopathy that kills more trauma patients than the original injury. As Sarah moved deeper into the technical aspects of her presentation, she began to notice something in the audience that made her increasingly uncomfortable. Several of the older physicians were exchanging glances that seemed to carry skeptical undertones, and she caught fragments of whispered conversations that suggested not everyone was fully accepting her expertise. Dr. Chen, interrupted Dr. Patricia Holbrook, a senior surgeon from a prestigious academic medical center. These techniques sound innovative, but I'm curious about the peer review process for medical protocols developed in military settings. How do we know that what worked in Afghanistan will be appropriate for civilian populations? The question carried an undertone that Sarah recognized immediately, the suggestion that military medicine was somehow less rigorous or less scientifically valid than civilian practice. It was a bias she had encountered repeatedly since beginning her civilian medical career, the assumption that combat experience was less valuable than traditional academic credentials. The protocols I'm discussing have been published in peer-reviewed journals and have undergone extensive validation in civilian settings, Sarah replied, her voice maintaining its professional tone despite the rising frustration she felt. The Journal of Trauma and Acute Care Surgery has published 12 papers on these techniques over the past 3 years. Dr. Holbrook consulted her tablet, presumably looking up Sarah's publications in real time. I see several papers here, but the co-authors are primarily military physicians. I'm wondering about independent validation from civilian academic institutions. The room had grown noticeably quieter, the earlier atmosphere of collegial learning replaced by the tension that comes when professional credentials are being questioned in public. Sarah could see younger physicians looking uncomfortable, caught between their interest in the medical content and their awareness that something more complex was happening at the interpersonal level. Ma'am, Marcus said from the back of the room, his voice cutting through the tension with military precision. I think there might be some confusion about the validation of combat medical techniques. Dr. Holbrook turned toward Marcus with a polite but dismissive attention she might give to an audience member who was interrupting a scientific presentation. Sir, while we appreciate your presence here, this is a discussion of medical protocols that requires— I've been treated using these protocols, Marcus interrupted, standing up with movements that drew attention from across the room. Not as a theoretical case study, but as someone bleeding out on a surgical table in Afghanistan. Dr. Chen's techniques didn't just pass peer review. They passed the test of keeping me alive when conventional approaches wouldn't have worked under those conditions. The room fell completely silent, Sarah felt her breath catch in her throat as Marcus continued, his voice carrying the authority of someone speaking from personal experience rather than theoretical knowledge. "I've been treated at Walter Reed, at civilian trauma centers, and at VA hospitals," Marcus continued. "The techniques Dr. Chen developed in combat zones are now standard of care at some of the best trauma centers in the country. The suggestion that military medicine is somehow less rigorous than civilian practice ignores the fact that combat surgeons often work under conditions that would shut down a civilian hospital." Dr. Morrison leaned back in his chair, his expression showing renewed interest in the discussion. "Can you elaborate on that? What conditions are we talking about?" Marcus looked at Sarah, seeking permission to share details that might be more personal than she wanted discussed in a professional setting. Sarah nodded, recognizing that Marcus's perspective might be more powerful than any statistical analysis she could provide. "Dr. Chen operated on me while the base was under mortar attack," Marcus said, his voice taking on the flat, factual tone that combat veterans used when describing traumatic events. "The surgical bunker was reinforced, but we could hear explosions landing close enough to shake the building. She had to decide whether to wait for the attack to end and let me bleed out, or continue operating while incoming fire was landing around us." The room remained silent, the civilian medical professionals struggling to imagine working under conditions that combined life-and-death medical decisions with immediate personal danger. Sarah remembered that night with crystal clarity. The sound of Marcus's labored breathing, the complexity of the vascular injury in his leg, and the constant background noise of the base's defensive systems engaging incoming mortars. "The patient had a severed femoral artery from shrapnel," Sarah said, taking over the narrative with clinical details that were easier for her to discuss than the emotional reality of operating under fire. "Standard civilian protocol would have been to move him to a more secure location before beginning surgery. We didn't have that option. I had to perform a complex vascular repair while the building was being shaken by explosions." Dr. Foster had been listening to this exchange with the fascination of someone whose psychiatric practice focused on trauma recovery. "Dr. Chen, how do you manage the psychological stress of making medical decisions under those conditions?" Sarah felt the familiar tightness in her chest that came whenever discussions moved from technical medical details to the human cost of combat medicine. "You learn to compartmentalize. During the surgery, you focus entirely on the technical aspects, the anatomy, the procedures, the patient's vital signs. The fear and the adrenaline become background noise that you filter out until the patient is stable." "And after the surgery?" Dr. Foster pressed gently. Sarah's hand moved unconsciously to the scar tissue around her left eye socket. "After the patient is stable, you deal with the psychological aftermath. Sometimes that processing happens immediately, sometimes it takes years. Many combat medical personnel suffer from PTSD, but we don't always recognize it because we were focused on saving lives rather than taking them." Marcus had returned to his seat, but his presence continued to add weight to Sarah's words. "The point," he said, "is that Dr. Chen didn't just develop these techniques in a laboratory or a simulation. She developed them while people were shooting at her, while making decisions that meant the difference between soldiers going home to their families or being shipped home in flag-draped coffins." Dr. Holbrook looked down at her tablet, perhaps reconsidering her earlier skepticism in light of the personal testimony she had just heard. "Dr. Chen, I apologize if my questions seem to challenge your credentials. I think what I was really asking about was the process of adapting combat-tested techniques for civilian use." Sarah nodded, accepting the apology while recognizing that the underlying bias, the assumption that military experience was somehow less valuable than traditional academic credentials, was a problem that extended far beyond this particular presentation. "The adaptation process is actually quite rigorous," she said, clicking to the next slide. "We conduct controlled studies in civilian trauma centers, comparing outcomes using traditional protocols versus combat-derived techniques. The data consistently shows improved survival rates and reduced complications." The presentation continued, but Sarah could sense that something fundamental had shifted in the room. The earlier atmosphere of collegial learning had been replaced by a more complex dynamic, one that reflected broader tensions about credibility, experience, and the ways that military service was valued, or not valued, in civilian professional settings. Dr. Kevin Walsh, a young trauma surgeon from a community hospital, raised his hand. "Dr. Chen, I'm curious about the training requirements for implementing these techniques." Do medical personnel need specific combat experience to apply these protocols effectively? That's an excellent question, Sarah replied, grateful for an opportunity to focus on practical applications rather than credential challenges. The techniques themselves can be taught to any qualified surgeon. However, the decision-making framework, knowing when to apply damage control principles versus attempting definitive repair, requires understanding the broader context of resource limitation and time pressure. Marcus stood up again, his movement drawing attention from across the room. Permission to add something to that? Sarah nodded, curious about what perspective Marcus would bring to the training discussion. The difference isn't just technical, Marcus said, addressing the room with the confidence of someone accustomed to briefing mixed military and civilian audiences. It's about accepting that sometimes the best medical decision isn't the perfect medical decision. In combat zones, Dr. Chen had to choose between procedures that might save one patient versus procedures that could save 3 patients with the same resources. The room grew quiet as the implications of Marcus's statement settled over the assembled medical professionals. Dr. Morrison leaned forward, his expression showing the uncomfortable recognition of someone confronting ethical dilemmas he hadn't previously considered. "Are you talking about medical triage and mass casualty situations?" Dr. Morrison asked. "I'm talking about resource allocation under extreme conditions," Marcus replied. Dr. Chen might have 30 minutes to save as many lives as possible before the next wave of casualties arrived. Perfect surgical technique becomes secondary to effective surgical technique when you're working with those constraints. Sarah felt the familiar weight of memories from deployment, the impossible decisions about resource allocation, the patients she had been able to save, and the ones she hadn't. This is why combat medicine has developed protocols that prioritize speed and effectiveness, she said. When you have multiple patients with life-threatening injuries and limited surgical resources, you learn to make decisions that maximize overall survival rather than pursuing perfect outcomes for individual patients. Dr. Jennifer Martinez, an emergency physician from a rural hospital, raised her hand. "Dr. Chen, this sounds extremely relevant for hospitals that serve remote areas with limited resources. How do we implement these protocols in settings where we might not have access to blood banks or specialized equipment?" Sarah clicked to a slide showing a field surgical kit laid out on a table, the essential instruments and supplies that could fit in 2 large backpacks but could support damage control surgery for multiple patients. "Part of combat medicine involves working with limited supplies," she said. "We developed protocols that assume you might not have access to ideal equipment or unlimited blood products." The presentation was beginning to regain its educational focus, but Sarah could still sense undercurrents of skepticism from some audience members. She noticed Dr. Holbrook whispering to a colleague, their body language suggesting continued doubt about the validity of military-derived medical protocols. It was then that Dr. Foster stood up, her movement deliberate and attention-getting. "Dr. Chen, I think some people in this audience might benefit from understanding the broader context of your military service. Could you share some details about the specific recognition you received for your combat medical work?" Sarah felt uncomfortable with the direction the conversation was taking. She had never been comfortable with public discussion of military decorations, preferring to let her medical work speak for itself. "Dr. Foster, I'd rather focus on the clinical applications." "Ma'am," Marcus interrupted, his voice carrying the tone of someone who understood the politics of credibility in mixed civilian-military settings. "With respect, I think Dr. Foster has a point. Some people in this room might not understand the significance of the decorations you've received." Sarah looked around the room, seeing a mixture of curiosity, support, and continued skepticism in the faces of her colleagues. She realized that Marcus and Dr. Foster were probably right. In a civilian setting, military decorations were often abstract concepts that didn't carry the weight they deserved. "I was awarded the Bronze Star Medal with Combat V for valor during a complex surgical operation under enemy fire," Sarah said quietly. The citation specifically mentions maintaining surgical operations while the facility was under direct attack, and for making decisions that saved 8 coalition soldiers during a 12-hour period when we were treating casualties from multiple IED attacks. Dr. Morrison looked up from his notes, his expression showing new understanding. "Dr. Chen, could you walk us through what maintaining surgical operations under enemy fire means in practical terms?" Sarah felt the familiar reluctance that came with discussing the most traumatic aspects of her deployment experience. The Bronze Star operation had been the longest and most challenging day of her military career, A day when everything that could go wrong had gone wrong, and when her decisions had meant the difference between soldiers living or dying. October 15, 2021, she began, her voice taking on the clinical tone she used when discussing difficult cases. We received 8 casualties from a convoy that had hit a complex IED attack. Multiple amputations, penetrating abdominal injuries, traumatic brain injuries. The kinds of wounds that require immediate surgical intervention to prevent death from hemorrhagic shock. Marcus was listening with obvious attention, recognizing the clinical description of the kind of attack that had defined his own deployment experience. He had been in convoys that hit IEDs, had seen the immediate aftermath of complex attacks, and understood the medical challenges that Sarah was describing. 4 hours into the surgical operations, Sarah continued, the base came under coordinated mortar and rocket attack. Standard protocol would have been to move patients to protective bunkers and wait for the attack to end. But several of the patients were in the middle of life-saving surgery. Stopping the operations would have meant certain death. The room had grown completely silent, civilian medical professionals trying to imagine making clinical decisions while under direct attack. Dr. Foster was taking notes, her psychiatric training making her acutely aware of the trauma inherent in the scenario Sarah was describing. I made the decision to continue operating, Sarah said, her voice remaining steady despite the emotional weight of the memory. We moved the most critical patients to the reinforced surgical bunker, but we kept operating while explosions were landing close enough to shake the building and disrupt our equipment. Dr. Walsh looked up from his notepad, his young face showing the particular fascination that junior physicians had for hearing about medicine practiced under extraordinary conditions. How do you maintain surgical precision when the building is being shaken by explosions? Sarah managed a small smile, remembering the dark humor that had kept her surgical team functional during the attack. You learn to work between explosions. The mortars came in patterns. We could usually predict when the next round was going to hit based on the timing of previous impacts. During the quiet intervals, we worked as quickly as possible. When we heard incoming rounds, we covered the patients and waited for the impacts to pass. Marcus stood up again, his movement drawing attention from across the room. Ma'am, was that the operation where you continued working after taking shrapnel yourself? Sarah felt her breath catch in her throat. She hadn't been planning to discuss her own injuries during the Bronze Star operation. It felt too much like seeking sympathy rather than sharing medical knowledge. But Marcus's question hung in the air, and she could see from the expressions around the room that her colleagues were waiting for an answer. I took minor shrapnel wounds from an explosion that hit close to the surgical bunker, she said quietly. Nothing that prevented me from continuing to operate. The patient's injuries were far more serious than mine. Minor shrapnel wounds, Marcus repeated, his voice carrying the tone of someone who understood military understatement. Ma'am, with respect, the citation for your Bronze Star mentions that you continued operating for 6 hours after being wounded, and that you refused medical treatment until all patients were stabilized. The room remained silent, the civilian medical professionals beginning to understand that they were hearing about a level of dedication and sacrifice that went far beyond normal professional duty. Dr. Morrison looked up from his notes, his expression showing the particular respect that came from recognizing exceptional performance under extraordinary conditions. Dr. Chen, Dr. Morrison said, I think I speak for everyone in this room when I say that we're honored to learn from someone who has served with such distinction. Your experience provides perspectives on trauma surgery that simply can't be gained in civilian practice. Sarah nodded, accepting the recognition while feeling the familiar discomfort that came with being praised for surviving situations that had broken other people. The point of sharing these experiences, she said, is to pass on knowledge that can save lives in civilian settings. The techniques we developed in combat zones have applications for mass casualty events, natural disasters, and resource-limited environments. But even as she spoke, Sarah could see that not everyone in the room was fully convinced. Dr. Holbrook was still whispering to her colleague, their body language suggesting continued skepticism about the relevance of military experience to civilian medical practice. Other older physicians seemed uncomfortable with the attention being paid to combat decorations rather than traditional academic credentials. Dr. Lisa Chen, no relation to Sarah despite the shared surname, raised her hand from the middle of the room. Dr. Chen, I'm curious about the peer review process for combat medical decisions. In civilian practice, we have ethics committees and case review processes. How are difficult decisions evaluated in military settings? The question carried an undertone that Sarah recognized immediately, the suggestion that military medicine operated without the ethical oversight and professional accountability that characterized civilian practice. It was another variation of the bias she had encountered repeatedly, the assumption that military service somehow involved less rigorous professional standards. Military medicine operates under the same ethical principles as civilian practice, Sarah replied, her voice showing the first signs of the frustration she had been suppressing throughout the presentation. We take the same oath to do no harm, we follow the same principles of medical ethics, and our decisions are subject to the same professional review processes. Dr. Chen consulted her notes, clearly preparing to pursue the line of questioning further. But in combat situations, aren't military physicians subject to orders from commanding officers? How do you maintain medical independence when you're part of a military command structure? Marcus stood up before Sarah could respond, his movement sharp enough to draw immediate attention from across the room. "Ma'am," he said, addressing Dr. Chen with barely controlled intensity, "I think you might be misunderstanding how military medicine actually works." Dr. Chen turned toward Marcus with the polite but dismissive attention she might give to someone who was interrupting a professional discussion. "Sir, while we appreciate your perspective, this is a question about medical ethics and professional standards. This is a question about whether you think military physicians are somehow less ethical than civilian physicians," Marcus interrupted, his voice carrying the edge that came when his protective instincts were fully engaged. "And as someone who has been treated by military medical personnel in life-and-death situations, I can tell you that your assumptions are not just wrong, they're insulting." The room had gone completely silent, the earlier atmosphere of collegial discussion replaced by open tension. Sarah felt the familiar weight of being caught between her military identity and her civilian professional life, trying to navigate institutional biases that treated her service as something to be overcome rather than valued. Dr. Foster stood up, her psychiatric training making her acutely aware of the group dynamics that were playing out in the conference room. "I think we might be losing sight of why we're here," she said, her voice carrying the calm authority of someone accustomed to managing difficult interpersonal situations. "Dr. Chen is sharing medical knowledge that has saved lives and can continue to save lives. Her military service and combat experience provide perspectives that enhance rather than diminish the value of her medical expertise." But the damage had been done. Sarah could see the room dividing along invisible lines, younger physicians and those with military connections showing support, while older academic physicians seemed to retreat into skepticism about military-derived medical protocols. The presentation had become less about sharing knowledge and more about defending the legitimacy of her experience. "Ladies and gentlemen," Sarah said, her voice cutting through the tension with surgical precision, "I think we need to address what's really happening in this room." The audience turned toward her with the focused attention that comes when someone is about to confront an uncomfortable truth. Sarah felt the weight of every bias she had encountered since beginning her civilian career, every subtle suggestion that military experience was somehow less valuable than traditional academic credentials. "Some of you are questioning whether military medicine is as rigorous as civilian practice," she continued, her voice remaining level despite the anger she felt building behind her sternum. "You're suggesting that combat experience might somehow compromise medical ethics or professional standards. You're treating my military service as something to be overcome rather than something that enhances my medical expertise." The room remained silent, civilian medical professionals confronting their own biases in the harsh light of public examination. Dr. Holbrook looked down at her tablet, perhaps recognizing that her earlier questions had revealed assumptions she hadn't intended to make explicit. "The reality," Sarah continued, "is that military medicine operates under standards that are often more rigorous than civilian practice. Combat physicians make life-and-death decisions under conditions that would shut down civilian hospitals. We operate with limited resources, under time pressure, and often while putting our own lives at risk to save others. Preparing and narrating this type of story took us long efforts and hard work, so if you are enjoying the story, please consider subscribing to our channel." Marcus was nodding from the back of the room, his expression showing the particular satisfaction that came from hearing someone articulate truths that needed to be spoken. "Dr. Chen is being polite," he said, his voice carrying across the silent room. "What she's not telling you is that military physicians often work under conditions that would be considered impossible in civilian settings, and they maintain standards of care that save lives when civilian protocols would fail. Dr. Morrison leaned forward, his expression showing the uncomfortable recognition of someone confronting professional biases he hadn't previously acknowledged. Dr. Chen, I think some of us owe you an apology. Your military service and combat experience should be recognized as assets that enhance your medical expertise, not obstacles to be overcome. Sarah nodded, accepting the apology while recognizing that the underlying problem extended far beyond this particular presentation. The bias against military experience in civilian professional settings was systemic, rooted in assumptions about the nature of military service that often had little basis in reality. The techniques I'm here to share, Sarah said, returning to her prepared presentation, have been validated in the most rigorous testing environment possible, actual combat conditions where failure means death. These protocols have been refined through years of treating wounded soldiers under impossible conditions, and they have applications that can save lives in civilian settings. But even as she spoke, Sarah could see that the room remained divided. The presentation had become a referendum on the value of military experience in civilian professional settings, and the outcome was far from certain. Some audience members were clearly supportive, while others seemed to retreat into skepticism about the relevance of combat medicine to civilian practice. The silence that followed Sarah's confrontation of institutional bias stretched across the conference room like a held breath, broken only by the soft hum of the air conditioning system and the distant sounds of the medical center continuing its daily operations. Dr. Amanda Foster cleared her throat, her psychiatrist's training making her acutely aware that the room had reached a critical moment that could either escalate into defensive conflict or evolve into meaningful dialogue. Dr. Chen, Dr. Foster said, her voice carrying the careful tone of someone trying to navigate emotionally charged waters, I think what's happening here reflects broader challenges that many veterans face when transitioning from military to civilian careers. Would you be willing to share your experience with that transition? Sarah looked around the room, seeing faces that reflected the full spectrum of human response to uncomfortable truths, some showing embarrassment at having their biases exposed, others displaying genuine curiosity about perspectives they hadn't previously considered, and a few revealing defensive skepticism about having their professional assumptions challenged. Marcus remained standing in the back, his presence both supportive and slightly intimidating in the way that reminded everyone in the room that they were discussing real people with real experiences, rather than abstract professional concepts. The transition was more challenging than I expected, Sarah began, her voice taking on the reflective tone of someone who had spent considerable time thinking about complex personal experiences. When you're a surgeon in a combat zone, your credentials are never questioned. If you can save lives under fire, if you can make impossible decisions under extreme pressure, your expertise is accepted without debate. The transition to civilian medicine involved constantly proving that military experience was valuable rather than something to be overcome. Dr. James Morrison shifted in his seat, his expression showing the uncomfortable recognition of someone confronting professional biases he hadn't previously acknowledged. Dr. Chen, can you give us specific examples of how military experience was devalued in civilian settings? Sarah felt the familiar tightness in her chest that came with discussing the more painful aspects of her post-military career. During my first civilian job interview, the department chief asked me whether I thought I could handle real medicine after spending years in what he called battlefield patch-up work. Another hospital administrator questioned whether someone with PTSD should be allowed to work in high-stress surgical environments. The room grew quieter, the civilian medical professionals beginning to understand that they were hearing about systematic discrimination rather than isolated incidents of professional skepticism. Dr. Foster was taking notes, her expression showing the particular interest that mental health professionals had when encountering examples of institutional bias that affected veteran populations. The assumption, Sarah continued, was that military medicine was somehow less sophisticated, less ethical, or less rigorous than civilian practice. I was asked to explain why military surgical experience should be considered equivalent to civilian residency training, as if operating under enemy fire was somehow less challenging than working in a fully equipped civilian hospital. Marcus stepped forward, his movement drawing attention from across the room. Ma'am, permission to share something that might help people understand what Dr. Chen is talking about. Sarah nodded, curious about what perspective Marcus would bring to the discussion of post-military career challenges. I spent 6 months at Walter Reed recovering from combat injuries, Marcus began, his voice carrying the matter-of-fact tone that combat veterans used when discussing traumatic experiences. During that time, I watched dozens of military medical personnel transition to civilian careers. The ones who struggled the most weren't struggling with their medical skills. They were struggling with civilian institutions that didn't understand or value their experience. Dr. Kevin Walsh, the young trauma surgeon, looked up from his notes with obvious curiosity. Can you elaborate on that? What specifically did civilian institutions not understand? Marcus looked directly at Dr. Walsh, his expression showing the particular patience that experienced warriors showed when educating younger people about realities they hadn't yet encountered. Civilian institutions often assume that military experience is narrow, that combat medicine is primitive, and that military personnel need to be retrained in real medicine when they transition to civilian careers. The reality is exactly the opposite. Dr. Patricia Holbrook had been listening to this exchange with growing discomfort, perhaps recognizing her own earlier questions in Marcus's description of institutional bias. Mr. Rodriguez, I think you might be overstating the case. Civilian medical institutions simply need to verify that military training meets civilian standards. Marcus turned toward Dr. Holbrook, with movements that were carefully controlled, his expression showing the particular intensity that came when his protective instincts were fully engaged. Ma'am, Dr. Chen developed surgical techniques that are now standard of care at Level 1 trauma centers across the country. Her protocols have reduced battlefield mortality rates by double digits. Her research has been published in the most prestigious medical journals in the world. What exactly needs to be verified? The room had grown tense again, the earlier attempt at dialogue threatening to evolve into open conflict between civilian assumptions and military experience. Sarah could see that Marcus's protective instincts were overriding his diplomatic training, and she recognized the need to redirect the conversation before it became unproductive. Marcus, she said quietly, using his first name deliberately to establish a more personal connection. I appreciate your support, but I think Dr. Holbrook's question reflects genuine concern about professional standards rather than intentional bias. Marcus looked at Sarah, his expression showing the internal struggle between his protective instincts and his respect for her judgment. Ma'am, with respect, some of the questions in this room have gone beyond professional standards into assumptions about the value of military service. Dr. Foster stood up, her movement designed to draw attention and shift the group dynamics that were threatening to become destructive. I think we're at a critical moment here, she said, her voice carrying the authority of someone accustomed to managing difficult group situations. We have an opportunity to learn from each other's perspectives, but only if we're willing to examine our own assumptions honestly. Sarah felt the weight of the moment, recognizing that the conversation had moved far beyond her original presentation to encompass broader questions about how military service was valued in civilian professional settings. The room contained over 100 medical professionals, many of whom would return to their own institutions with whatever understanding they developed during this discussion. Dr. Foster is right, Sarah said, her voice cutting through the tension with surgical precision. We need to examine our assumptions honestly. But that examination needs to go both ways. She looked around the room, making eye contact with audience members across the full spectrum of apparent support and skepticism. Some of you came into this presentation assuming that military medicine was somehow less rigorous or less valuable than civilian practice. But some military personnel make the opposite assumption, that civilian medicine is soft, that civilian physicians don't understand what real pressure looks like. Marcus nodded, recognizing the truth in Sarah's statement, even as his protective instincts remained engaged. Dr. Chen is right. I've made assumptions about civilian medicine that weren't fair. But the difference is that my assumptions don't affect whether civilian physicians get hired, get promoted, or get their expertise recognized. Dr. Morrison leaned forward, his expression showing genuine interest in understanding the systemic nature of the problem they were discussing. Dr. Chen, what would need to change for military medical experience to be properly valued in civilian settings? Sarah felt the familiar weight of being asked to solve problems that extended far beyond her individual experience. Part of the problem is educational, she said. Civilian medical professionals often don't understand what military medicine actually involves. The assumption is that it's primitive field medicine rather than sophisticated trauma surgery performed under extraordinary conditions. She clicked to the next slide in her presentation, which showed a photograph of a forward surgical team operating with equipment that would be recognizable in any civilian trauma center. Modern combat medicine uses the same technology, the same techniques, and the same professional standards as civilian medicine. The difference is the environment, not the medicine. Dr. Jennifer Martinez, the emergency physician from the rural hospital, raised her hand. Dr. Chen, what about the argument that combat medicine involves different ethical considerations? The question about following military orders versus maintaining medical independence. Sarah had been expecting this question, and she felt the familiar frustration of having to defend the ethical foundations of military medicine. Military medical officers take the same oath as civilian physicians, she said. We swear to do no harm, to put patient welfare first, and to maintain professional ethical standards. Military command structure doesn't override medical ethics. It provides the organizational framework within which medical ethics are practiced. Marcus stepped forward again, his movement showing the controlled intensity of someone who had reached the limits of his diplomatic patience. Ma'am, I think some people in this room don't understand what military medical ethics actually look like in practice. Dr. Martinez looked toward Marcus with obvious curiosity. Can you give us an example? Marcus looked at Sarah, seeking permission to share details that might be more personal than she wanted discussed in a professional setting. Sarah nodded, recognizing that Marcus's perspective might be more powerful than any abstract discussion of medical ethics. Dr. Chen saved my leg, Marcus said, his voice taking on the tone of someone delivering testimony under oath. But before she operated on me, she had to decide whether to use limited blood products on me or save them for a 19-year-old kid who had stepped on an IED. She chose to use creative surgical techniques that didn't require as much blood, so both of us could survive. The room remained silent, civilian medical professionals trying to imagine making resource allocation decisions under conditions where multiple lives hung in the balance. Dr. Foster was listening with obvious fascination, recognizing the ethical complexity of decisions that combined medical expertise with combat conditions. That's military medical ethics, Marcus continued. Not following orders blindly, but making decisions that maximize the number of people who survive. Dr. Chen could have taken the easy path and used all available resources on the first patient, but she found a way to save both of us. Dr. Walsh looked up from his notes, his young face showing the particular awe that junior physicians had when confronting the realities of advanced medical practice. Dr. Chen, how do you make those kinds of decisions? How do you balance individual patient care with resource limitations? Sarah felt the familiar weight of discussing decisions that had shaped her understanding of medical ethics under extreme conditions. You develop decision-making frameworks that prioritize overall survival while maintaining individual patient advocacy, she said. It's not about choosing who lives and who dies. It's about finding creative solutions that maximize positive outcomes for everyone. She clicked to the next slide, which showed a flowchart for resource allocation decisions in mass casualty situations. These protocols are now used in civilian disaster medicine, pandemic response, and mass casualty events. The ethical frameworks developed in combat zones have applications wherever resources are limited and demand exceeds capacity. Dr. Holbrook had been listening to this exchange with growing awareness of the complexity of the ethical and professional issues being discussed. Dr. Chen, I owe you an apology, she said, her voice showing the particular humility that came from recognizing significant professional errors. My earlier questions reflected assumptions about military medicine that were both unfair and inaccurate. Sarah nodded, accepting the apology while recognizing that individual acknowledgments of bias, while important, didn't address the systemic nature of the problem. Dr. Holbrook, I appreciate that. But the issue extends beyond individual attitudes to institutional policies and professional practices that systematically undervalue military experience. Marcus had returned to his seat, but his presence continued to add weight to the discussion. The question, he said, is what civilian institutions are going to do with this understanding. Are you going to continue assuming that military experience is something to be overcome? Or are you going to recognize it as an asset that enhances medical practice? Dr. Morrison looked around the room, his expression showing the particular thoughtfulness that came from someone trying to process complex new information. Dr. Chen, what would it look like for civilian medical institutions to properly value military experience? Sarah felt the opportunity to move the conversation from recognition of problems toward development of solutions. It would mean recognizing military medical experience as equivalent to civilian experience for hiring and promotion decisions, she said. It would mean understanding that combat medicine often involves more complex decision-making and more challenging conditions than civilian practice. Dr. Foster leaned forward, her expression showing obvious interest in the institutional change implications of the discussion. Dr. Chen, what about the psychological support aspects? How do civilian institutions need to adapt to support veterans who are transitioning from military to civilian medical careers? Sarah felt the familiar tightness in her chest that came whenever discussions moved toward the mental health aspects of military to civilian transition. Many military medical personnel suffer from PTSD related to their combat experience, she said. But civilian institutions often assume that mental health challenges disqualify someone from high-stress medical work, when the reality is that combat experience often enhances decision-making under pressure. She touched the scar tissue around her left eye socket, a gesture that had become unconscious over the years. I have been asked in job interviews whether my PTSD would prevent me from handling emergency situations. The question reflects a fundamental misunderstanding of how combat experience affects medical practice. Marcus stood up again, his movement showing the controlled energy of someone who had reached the limits of his patience with institutional ignorance. Ma'am, if I may, Drive Chen's PTSD doesn't make her less capable of handling emergencies. It makes her more capable, because she's already proven she can maintain clinical judgment under conditions that would shut down most civilian hospitals. Dr. Walsh looked between Sarah and Marcus, his expression showing the particular fascination that young physicians had when encountering perspectives they hadn't previously considered. Dr. Chen, how has your combat experience affected your approach to civilian emergency medicine? Sarah felt the opportunity to redirect the conversation toward practical applications, rather than theoretical discussions of bias and discrimination. Combat experience teaches you to stay calm under pressure, to make rapid decisions with incomplete information, and to prioritize effectively when resources are limited, she said. Those skills transfer directly to civilian emergency medicine. She clicked to the next slide, which showed comparative mortality statistics from emergency departments that employed military-trained physicians versus those that didn't. Hospitals that actively recruit military medical personnel show consistently better outcomes in trauma cases, mass casualty events, and high-acuity emergency situations. The data on the screen seemed to shift the room's energy, moving the discussion from abstract questions about bias toward concrete evidence of improved patient outcomes. Dr. Morrison was studying the statistics with obvious interest, his expression showing the particular attention that medical administrators paid to data that suggested improved performance metrics. These numbers are impressive, Dr. Morrison said. Dr. Chen, do you have information about the specific factors that account for improved outcomes? Sarah felt the satisfaction of returning to evidence-based discussion rather than defensive explanations of military credibility. Military medical personnel are trained to work under pressure to make decisions quickly and to adapt protocols to unusual circumstances, she said. In civilian emergency departments, those skills translate to better performance during mass casualty events, natural disasters, and high-stress situations. Dr. Martinez was taking notes rapidly, her expression showing the particular excitement that rural physicians had when discovering resources that could improve their ability to serve isolated communities. Dr. Chen, would these techniques be applicable in resource-limited rural settings? Absolutely, Sarah replied, clicking to a slide that showed a rural hospital's improved trauma outcomes after implementing combat-derived protocols. Rural emergency departments often face resource limitations similar to forward surgical teams. Combat-tested techniques for managing complex trauma with limited equipment have direct applications in rural settings. The room's energy had shifted completely, the earlier tension about military credibility replaced by genuine professional interest in practical applications. Dr. Foster was watching the group dynamics with obvious satisfaction, recognizing that the conversation had evolved from defensive conflict to productive dialogue. Dr. Chen, Dr. Foster said, I think what we're seeing here is the importance of recognizing military experience as an asset rather than something to be overcome. The question is how we institutionalize that recognition. Sarah nodded, feeling the weight of being asked to solve problems that extended far beyond her individual experience. It requires changing hiring practices, promotion criteria, and professional development programs to recognize military experience as valuable preparation for civilian medical practice, rather than something that needs to be supplemented or corrected. Marcus had been listening to this exchange with obvious satisfaction, recognizing that the conversation had moved toward the kind of systemic change that could benefit other veterans transitioning to civilian careers. The bottom line, he said, is that military medical personnel bring skills and experience that enhance civilian medical practice. The question is whether civilian institutions are smart enough to recognize and utilize those assets. Dr. Morrison looked around the room, his expression showing the particular thoughtfulness that came from someone processing information that challenged fundamental professional assumptions. "I think we owe Dr. Chen a debt of gratitude," he said, "not just for the medical knowledge she's sharing, but for helping us recognize biases that affect how we evaluate and utilize military medical experience." The room broke into applause, the sound carrying a weight that went beyond polite appreciation for a professional presentation. Sarah felt the familiar mix of pride and discomfort that came with public recognition, but also a deeper satisfaction at having moved the conversation toward understanding rather than defensiveness. "Hey, Wajah." As the applause faded, Sarah looked around the room and saw faces that reflected genuine understanding rather than skeptical curiosity. The presentation had become more than an educational session about trauma surgery techniques. It had become an examination of how military service was valued in civilian professional settings, and the outcome suggested that meaningful change was possible. 6 months after the presentation at the VA Medical Center, Dr. Sarah Chen stood in the conference room of Presbyterian Medical Center, looking out at an audience that would have been unimaginable during her early days of civilian medical practice. The room was filled with hospital administrators, department chiefs, and senior physicians from medical institutions across the region, all gathered for the inaugural meeting of the Military Medical Integration Initiative, a program designed to actively recruit, support, and advance military medical personnel in civilian healthcare settings. The initiative had grown out of the conversations that began during Sarah's controversial presentation, rippling outward through professional networks, social media discussions, and institutional policy reviews that had forced civilian medical organizations to examine their assumptions about military experience. Dr. James Morrison, now serving as the initiative's civilian medical director, had spent months developing partnerships with veterans organizations, medical schools, and hospital systems to create pathways for military medical personnel to transition successfully to civilian careers. "Ladies and gentlemen," Dr. Morrison began, his voice carrying the enthusiasm of someone who had discovered a solution to problems he hadn't previously recognized. 6 months ago, many of us learned that we had been systematically undervaluing one of the most important resources available to civilian healthcare, the expertise and experience of military medical personnel. Sarah sat at the head table alongside Marcus Rodriguez, who had become an unexpected advocate for veteran healthcare issues after his confrontation with institutional bias during her presentation. Marcus had leveraged his special operations background and his powerful personal testimony to open doors in both military and civilian organizations, creating bridges between communities that had previously operated in isolation from each other. The transformation had begun immediately after Sarah's presentation, when Dr. Amanda Foster had returned to her VA psychiatric practice with a new understanding of the challenges that military medical personnel faced during civilian career transitions. Within weeks, Dr. Foster had developed a support program specifically designed to help veteran healthcare workers navigate the cultural and professional differences between military and civilian medical practice. "The data we've collected over the past 6 months," Dr. Morrison continued, clicking to a slide that showed improved patient outcomes across multiple hospital systems, demonstrates conclusively that actively recruiting and supporting military medical personnel improves healthcare delivery in measurable ways. The statistics on the screen told a story that went far beyond Sarah's individual experience. Emergency departments that had hired military-trained physicians showed 17% better outcomes in trauma cases. Surgical teams that included combat veterans demonstrated improved performance during mass casualty events. Rural hospitals that had recruited military medical personnel reported better retention rates and higher patient satisfaction scores. Dr. Patricia Holbrook, who had become one of the initiative's most vocal supporters after recognizing her own biases during Sarah's presentation, stood up to address the audience. "I want to share something personal," she said, her voice carrying the particular humility that came from acknowledging significant professional errors. 6 months ago, I questioned whether military medical experience was equivalent to civilian training. I was wrong, and my error reflected assumptions that are widespread in civilian medical institutions. Sarah felt the familiar mix of vindication and sadness that came with watching institutional change develop in response to problems that should never have existed in the first place. The initiative represented progress, but it also highlighted how many military medical personnel had been undervalued or overlooked during their civilian career transitions. Marcus leaned forward to the microphone, his presence adding weight to the proceedings in the way that authentic military experience always did when civilian institutions were discussing veteran issues. Dr. Holbrook's honesty is important, he said, his voice carrying the authority of someone who had been on the receiving end of institutional bias. But we need to understand that this isn't just about individual attitudes. It's about systemic problems that affect thousands of veterans. The room had grown quiet, civilian medical professionals recognizing that they were hearing about experiences that extended far beyond the individuals at the head table. Sarah had spent the past 6 months collecting stories from military medical personnel who had struggled with civilian career transitions, and the patterns that emerged painted a picture of widespread institutional bias that had been largely invisible to the civilian medical community. The initiative has already helped place 47 military medical personnel in civilian positions, Dr. Morrison announced, his voice showing the satisfaction of someone who had discovered that solving problems could be both personally fulfilling and professionally beneficial. More importantly, we've developed training programs that help civilian institutions understand and utilize military medical experience effectively. Dr. Jennifer Martinez, the rural emergency physician who had been so interested in resource-limited protocols during Sarah's original presentation, stood up to share her experience with the initiative. Presbyterian Rural Network has hired 3 military-trained emergency physicians in the past 4 months, she said. Our trauma outcomes have improved dramatically, and our staff morale has increased because we finally have the expertise to handle complex cases that we previously had to transfer to urban centers. Sarah felt the deep satisfaction that came from seeing practical applications of the knowledge she had fought to have recognized. The combat-derived protocols that had once been questioned as potentially inferior to civilian medicine were now being actively sought out by hospitals trying to improve their emergency care capabilities. The presentation continued with testimonials from hospital administrators who had discovered that military medical personnel brought not just technical expertise but also leadership skills, crisis management experience, and the particular kind of calm competence that came from having worked under extreme pressure. The initiative had evolved beyond a simple job placement to encompass comprehensive support for military to civilian career transitions. Dr. Foster stood up to discuss the mental health aspects of the initiative, her psychiatric expertise providing crucial insight into the psychological challenges that military medical personnel faced during civilian career transitions. We've learned that many veterans struggle not with their medical skills but with institutional cultures that don't understand or value their experience, she said. The initiative provides both professional support and psychological resources to help veterans navigate these challenges. Sarah thought about her own transition experiences, the months of proving her competence to colleagues who assumed that military medicine was somehow primitive or less rigorous than civilian practice. The initiative represented the kind of systematic support that could have made her transition easier and more successful. Dr. Chen, Dr. Morrison said, turning towards Sarah with obvious respect, would you share your perspective on how the initiative addresses the challenges you faced during your own civilian transition? Sarah stood up, looking out at an audience that now included many of the people who had witnessed her confrontation with institutional bias 6 months earlier. The room felt different now. Instead of skeptical curiosity, she saw genuine interest in understanding and addressing problems that affected veteran healthcare workers. The initiative addresses 3 critical areas, Sarah began, her voice carrying the confidence that came from having her expertise finally recognized and valued. Professional recognition, institutional support, and peer connection. For too long, military medical personnel have been isolated during their civilian transitions, forced to navigate cultural differences and professional biases without adequate support. She clicked to the next slide, which showed a network diagram of the relationships that the initiative had fostered between military and civilian medical professionals. The initiative creates communities where veterans can share experiences, mentor each other, and advocate collectively for recognition of military medical expertise. Marcus nodded, recognizing the truth in Sarah's analysis from his own experience with veteran support networks. The isolation is real, he said. When you transition from military to civilian life, you lose the automatic recognition and support that comes with wearing the uniform. Civilian institutions often don't understand what that loss means for someone who has spent years serving in high-stakes environments. Dr. Kevin Walsh, the young trauma surgeon who had been so interested in combat medicine during Sarah's original presentation, raised his hand. Dr. Chen, how has the initiative changed your own professional experience? Sarah felt the weight of the question, recognizing that her answer would reflect not just her individual experience but the broader impact of systematic institutional change. The initiative has created space for military medical experience to be recognized as an asset rather than something to be overcome, she said. I no longer have to constantly prove that combat medicine is real medicine. Instead, I can focus on sharing knowledge and techniques that save lives. The transformation in Sarah's professional life had been dramatic. Instead of being questioned about the legitimacy of her credentials, she was now actively sought out for her expertise in trauma surgery, crisis management, and resource-limited protocols. The Bronze Star Medal that had once been dismissed as irrelevant to civilian medicine was now recognized as evidence of exceptional performance under extraordinary conditions. Dr. Morrison looked around the room, his expression showing the particular satisfaction that came from witnessing institutional change that produced measurable improvements in patient care. The initiative has demonstrated that actively recruiting and supporting military medical personnel isn't just good for veterans, it's good for healthcare delivery overall. The statistics supported Dr. Morrison's assertion conclusively. Hospitals that participated in the initiative showed improved performance across multiple metrics, from trauma outcomes to staff retention to patient satisfaction. The systematic integration of military medical expertise had created a rising tide that lifted all aspects of healthcare delivery. We've also learned, Dr. Foster added, that supporting veteran transitions benefits the broader medical community by introducing different perspectives on crisis management, resource allocation, and clinical decision-making under pressure. Sarah nodded, thinking about the ways that military experience had shaped her approach to civilian medical practice. The ability to maintain clinical judgment under pressure, to make rapid decisions with incomplete information, and to adapt protocols to unusual circumstances had applications that extended far beyond combat medicine. The meeting continued with presentations from medical school deans who had modified their residency programs to better accommodate military medical experience, hospital administrators who had developed recruitment strategies specifically targeting veteran healthcare workers, and policymakers who were working to ensure that military medical training received appropriate credit in civilian professional settings. One particularly significant development had been the creation of accelerated residency tracks for military physicians, recognizing that combat experience provided practical training that was equivalent to or exceeded civilian residency requirements in many specialties. The program had been controversial initially, with some civilian medical educators arguing that military experience couldn't substitute for traditional academic training. Dr. Holbrook had become one of the strongest advocates for the accelerated tracks after reviewing the performance data of military physicians who had completed the program. The evidence is overwhelming, she said, addressing concerns about the rigor of accelerated training. Military physicians who complete these tracks consistently outperform traditionally trained residents in high-pressure situations and complex case management. Sarah had been one of the first physicians to complete an accelerated track, using her combat experience to fast-track through a civilian trauma surgery fellowship that normally took 2 years. The program had allowed her to advance to department chief level more quickly, while ensuring that her military-derived expertise was formally recognized and credentialed. The initiative had also created research opportunities that were producing new knowledge about trauma care, emergency medicine, and crisis management. Sarah was leading a multi-center study comparing outcomes between military-derived protocols and traditional civilian approaches, with preliminary results showing significant improvements in survival rates for complex trauma cases. Marcus had become involved in the research as well, providing the patient perspective on military medical care that was often missing from academic studies. His testimony about the psychological impact of receiving care from military medical personnel had opened new avenues of research into the relationship between provider experience and patient outcomes. The next phase of the initiative, Dr. Morrison announced, will focus on expanding beyond individual hospital systems to create regional networks that can share resources, expertise, and best practices for integrating military medical personnel into civilian healthcare. The regional approach reflected lessons learned during the first 6 months of the initiative. While individual hospitals had achieved impressive results, the greatest impact came when multiple institutions worked together to create comprehensive support systems for veteran healthcare workers. Dr. Martinez had been instrumental in developing the rural component of the regional networks, recognizing that military medical personnel were particularly well-suited for the resource-limited environments that characterized rural healthcare. Military-trained physicians and nurses understand how to provide high-quality care with limited resources, she said. Those skills are exactly what rural hospitals need to serve their communities effectively. The rural networks had become one of the initiative's most successful components, with small hospitals across the region reporting dramatic improvements in their ability to handle emergency cases, trauma situations, and complex medical conditions that previously required expensive transfers to urban medical centers. Sarah stood up to make the closing remarks for the meeting, looking out at an audience that represented the kind of institutional change she had never imagined possible when she first encountered skepticism about her military credentials. 6 months ago, many of us learned that institutional bias was preventing civilian healthcare from utilizing one of its most valuable resources, the expertise and experience of military medical personnel. The room remained silent, civilian medical professionals reflecting on the journey they had taken from unconscious bias to active recruitment and support of veteran healthcare workers. Sarah could see in their faces the recognition that the initiative represented more than just improved staffing. It represented a fundamental shift in how military service was valued in civilian professional settings. Today, Sarah continued, we have evidence that actively supporting military medical personnel improves healthcare delivery in measurable ways. But more importantly, we have created communities where veterans can contribute their expertise without having to constantly defend the legitimacy of their experience. Marcus nodded from his seat, recognizing the profound importance of what Sarah was describing. The initiative had created space for military experience to be recognized as an asset rather than something to be overcome, and that recognition had ripple effects that extended far beyond individual career outcomes. The initiative represents a model for how civilian institutions can recognize and utilize military expertise, Sarah said. But our success here needs to be replicated in other regions, other specialties, and other professional settings where veterans struggle with civilian career transitions. Hi, Dr. Morrison stood up to conclude the meeting, his voice carrying the conviction of someone who had witnessed institutional change produce meaningful improvements in people's lives. The Military Medical Integration Initiative has demonstrated that recognizing and supporting military expertise isn't just the right thing to do, it's the smart thing to do for healthcare delivery overall. As the meeting concluded and participants began to file out of the conference room, Sarah reflected on the journey that had brought her from the security checkpoint confrontation to this moment of institutional recognition and systematic change. The path had been marked by frustration and struggle, but it had led to outcomes that would benefit thousands of veterans and millions of patients who would receive better care, because military medical expertise was finally being recognized and utilized effectively. The initiative represented more than just improved job placement for veterans. It represented a fundamental shift in how military service was valued in civilian professional settings. And as Sarah gathered her materials and prepared to return to her work as Chief of Trauma Surgery, she knew that the real measure of the initiative's success would be found in the lives saved by the knowledge and experience that military medical personnel brought to civilian healthcare. 3 years later, the morning sun streamed through the windows of the new Military Medical Excellence Center at Presbyterian Medical Center, illuminating walls lined with photographs that told the story of combat medicine's evolution, from battlefield necessity to civilian healthcare innovation. Dr. Sarah Chen walked through the corridors of the facility that bore her name, the Dr. Sarah Chen Combat Medicine Institute, though she had argued strenuously against the personal recognition, preferring that the focus remain on the broader mission of supporting veteran healthcare workers. The center had become a national model for military to civilian medical career transitions, attracting visitors from across the country who wanted to understand how systematic institutional change could transform both veteran employment outcomes and healthcare delivery quality. Sarah paused in front of a photograph showing herself and Marcus Rodriguez at the White House, receiving the Presidential Medal of Freedom for their work in advancing veteran healthcare integration. "Dr. Chen," came a voice from behind her. Sarah turned to see Dr. Emily Rodriguez, no relation to Marcus, a young Army emergency physician who had recently completed the accelerated civilian residency track that had become the center's signature program. Emily's face still carried the particular intensity that marked recent combat veterans, her eyes holding the weight of experiences that most people her age would never encounter. "Good morning, Emily," Sarah replied, noting the nervous energy in the younger woman's posture. "How are you feeling about your first day as attending physician?" Emily managed a smile that didn't quite reach her eyes. "Honestly, terrified. I know the medicine backward and forward, but I'm still getting used to the idea that my military experience is seen as an asset here, rather than something I need to overcome." Sarah felt the familiar recognition that came from seeing her own journey reflected in another veteran's experience. "That feeling will pass," she said. "The center exists specifically to ensure that people like us never have to justify our credentials or downplay our experience to fit into civilian medicine." The conversation was interrupted by the arrival of Dr. Marcus Thompson, a civilian emergency physician who had completed one of the center's reverse integration programs, spending 6 months with military medical units to understand combat medicine techniques firsthand. The program had become popular among civilian physicians who wanted to enhance their trauma skills and crisis management capabilities. "Dr. Chen," Marcus Thompson said, his excitement obvious despite his attempt at professional composure, "the rural network implementation in Montana is showing even better results than we projected. Mortality rates for complex trauma cases have dropped by 28% since we started deploying military-trained teams to underserved areas." Sarah felt the deep satisfaction that came from seeing systematic solutions address problems that had once seemed intractable. The center's rural deployment program had become one of its most successful initiatives, sending teams of military medical personnel to remote areas where their ability to provide high-quality care with limited resources had transformative effects on community health outcomes. "That's excellent news," Sarah replied. "What about the provider satisfaction metrics?" "Through the roof," Marcus Thompson said, consulting his tablet for specific data. "The military-trained personnel report high job satisfaction because they're using their full skill set, and the civilian staff are enthusiastic about the new techniques and protocols they're learning." The success of the rural programs had attracted attention from international humanitarian organizations, which had begun recruiting center graduates for disaster response and global health initiatives. Sarah had been invited to consult on medical response protocols for refugee camps, natural disaster zones, and other resource-limited environments where combat-derived medical techniques had immediate applications. As they walked toward the morning briefing room, Sarah reflected on how dramatically the landscape of military to civilian medical transitions had changed over the past 3 years. What had begun as a single confrontation over an ID verification had evolved into a national movement that was transforming healthcare delivery while providing meaningful career opportunities for veteran medical personnel. The briefing room was filled with the usual mix of military and civilian medical professionals who now worked together so seamlessly that the distinctions had become largely irrelevant. Dr. Amanda Foster, now the center's director of psychological services, was presenting data on veteran mental health outcomes, showing that systematic professional support and recognition had dramatic positive effects on PTSD symptoms and overall psychological well-being. "The correlation is striking," Dr. Foster was saying, pointing to charts that showed improved mental health metrics among veterans who had found meaningful employment in healthcare settings that valued their military experience. When veterans feel that their service is recognized and utilized, their psychological adjustment to civilian life improves dramatically. Sarah took her seat at the head of the conference table, looking around at faces that represented the full spectrum of military and civilian medical expertise. The morning briefings had become one of her favorite parts of the job, moments when the artificial barriers between military and civilian medicine disappeared entirely, replaced by shared commitment to saving lives and advancing medical knowledge. "Before we begin," Sarah said, addressing the assembled group, "I want to share some news that reflects how far we've come. The Department of Veterans Affairs has announced that our model for military medical integration will be implemented at all VA medical centers nationwide. Additionally, the Association of American Medical Colleges has revised their accreditation standards to ensure that military medical experience receives appropriate recognition in civilian training programs." The room erupted in applause, the sound carrying the weight of institutional change that had seemed impossible just 3 years earlier. Sarah felt the familiar mix of pride and disbelief that came with witnessing systematic transformation of institutions that had once seemed immovable. Marcus Rodriguez entered the briefing room during the applause, his presence still carrying the particular authority that came from being the person whose testimony had helped spark the movement. He had become the center's director of veteran advocacy, using his special operations background and powerful speaking abilities to open doors in both military and civilian organizations. "Sorry I'm late," Marcus said, taking his seat with movements that still showed the careful precision of someone whose left leg bore the scars of combat surgery. "I was on a call with the Pentagon about expanding the reverse integration program to include special operations medical personnel." The reverse integration program had become one of the center's most innovative initiatives, allowing civilian medical personnel to train with military units to understand combat medicine techniques while providing military medical personnel with opportunities to learn cutting-edge civilian techniques and technologies. Yaker, Dr. Jennifer Martinez, now the center's director of rural medicine programs, leaned forward with obvious excitement. "Marcus, does that mean we'll have access to special operations medical protocols for the rural emergency medicine curriculum?" Marcus nodded, his expression showing the satisfaction that came from breaking down barriers that had traditionally separated military and civilian medical communities. "The program will allow civilian emergency physicians to train with special operations medics, learning techniques for providing advanced medical care in austere environments. In exchange, military medics will train in civilian trauma centers to learn the latest surgical techniques and medical technologies." Sarah felt the weight of how far they had traveled from that initial confrontation in the VA cafeteria. The center now facilitated knowledge exchange between military and civilian medical communities that was improving outcomes on both sides, creating a virtuous cycle of innovation and expertise sharing that benefited everyone involved. The briefing continued with updates from various programs that had grown out of the center's original mission. Dr. Patricia Holbrook, now serving as the center's academic liaison, reported on medical school curriculum changes that were incorporating combat medicine techniques into trauma surgery training. Dr. Kevin Walsh had become the center's research director, leading studies that were producing new knowledge about emergency medicine, crisis management, and resource-limited care protocols. One particularly significant development had been the creation of the Global Health Initiative, which deployed center-trained teams to provide medical care in conflict zones, refugee camps, and disaster areas where combat-derived medical techniques had immediate life-saving applications. The program had attracted international recognition and funding, establishing the center as a leader in humanitarian medical response. Dr. Chen, said Dr. Lisa Park, a Korean War veteran who had joined the center's advisory board, "I want you to know what this place means to people like me. I spent 40 years feeling like my military medical experience was something to be ashamed of rather than proud of. This center has changed that for thousands of veterans." Sarah felt the familiar tightness in her throat that came whenever older veterans shared their experiences with institutional bias and recognition. Dr. Park represented a generation of military medical personnel who had served with distinction but had struggled to have their experience valued in civilian settings. "Dr. Park," Sarah replied, "the center exists because people like you paved the way. Your generation's service created the foundation of knowledge that we're building on today." The briefing concluded with announcements about upcoming initiatives, including a partnership with NASA to develop medical protocols for space exploration that drew heavily on combat medicine techniques for providing care in resource-limited environments. The partnership reflected how broadly the principles of combat medicine were being recognized as applicable to extreme environments beyond traditional military settings. As the meeting dispersed and participants returned to their various duties, Sarah walked to her office, passing walls lined with thank you letters from patients whose lives had been saved by combat-derived medical techniques, photographs of center graduates deploying to disaster zones around the world, and certificates recognizing the center's contributions to advancing medical knowledge and veteran employment. Her office overlooked the center's simulation laboratory, where military and civilian medical personnel trained together on scenarios that combined the technical complexity of modern medicine with the resource limitations and time pressure that characterized combat environments. The lab had become a model for medical training programs across the country, demonstrating how military experience could enhance civilian medical education. Sarah sat down at her desk, looking out at the simulation lab where a mixed team of military and civilian physicians was working through a mass casualty scenario. The sight reminded her of her deployment days, but without the fear and uncertainty that had characterized those experiences. Here, the knowledge gained through combat was being used to prepare others to save lives rather than to treat the consequences of violence. 5 years later, the auditorium at the National Military Medical Conference was packed beyond capacity, with overflow crowds watching via live stream as Dr. Sarah Chen delivered the keynote address on the 5th anniversary of the Military Medical Integration Initiative. The annual conference had become the premier gathering for military and civilian medical professionals, reflecting how completely the artificial barriers between the two communities had been eliminated. 5 years ago, Sarah began, her voice carrying clearly across the packed auditorium, many of us learned that we had been operating under assumptions about military and civilian medicine that were preventing us from providing the best possible care to our patients. The audience included the full spectrum of healthcare professionals, from recent medical school graduates to senior department chiefs, from active-duty military physicians to veteran healthcare workers who had successfully transitioned to civilian careers. The diversity reflected how thoroughly the integration initiative had transformed the landscape of American healthcare. Today, Sarah continued, we have evidence that systematic integration of military medical expertise has improved healthcare delivery across every metric we measure: survival rates, patient satisfaction, provider retention, and cost-effectiveness. The data supporting Sarah's statement was overwhelming. Healthcare systems that had implemented military medical integration programs showed consistently better outcomes than those that hadn't. The techniques and protocols developed in combat zones had become standard of care in trauma centers, emergency departments, and rural hospitals across the country. Marcus Rodriguez, now serving as the National Director of Veteran Medical Integration, stood up to address the audience from his position at the head table. Dr. Chen is being modest, he said, his voice carrying the authority that came from having witnessed the transformation from its earliest stages. The initiative hasn't just improved healthcare delivery, it's changed how we think about service, expertise, and the value of military experience in civilian society. The broader implications of the military medical integration movement had indeed extended far beyond healthcare. Other professional fields had begun implementing similar programs to recognize and utilize military experience in engineering, technology, education, and business management. The healthcare initiative had become a model for systematic institutional change that recognized military service as an asset rather than something to be overcome. Dr. Amanda Foster, now serving as the National Director of Veteran Mental Health Integration, presented data showing that systematic professional recognition and support had dramatically improved mental health outcomes for veterans across all service branches and deployment experiences. When we recognize and utilize military experience appropriately, she said, we don't just improve professional outcomes, we improve the psychological well-being of the people who served our country. The conference continued with presentations from medical professionals around the world who had implemented versions of the military medical integration model in their own healthcare systems. The techniques and organizational approaches developed in American combat zones were being adapted for humanitarian crises, natural disasters, and resource-limited healthcare environments globally. One particularly moving presentation came from Dr. Elena Vasquez, a civilian physician who had completed the reverse integration program and subsequently deployed with Doctors Without Borders to provide emergency medical care in refugee camps. The crisis management skills and resource allocation techniques I learned from military medical personnel, she said, were essential for providing effective care in environments where traditional civilian medical approaches would have failed. Sarah listened to the presentations with the deep satisfaction that came from seeing systematic change produce measurable improvements in people's lives. The initiative had evolved far beyond her individual experience to encompass fundamental shifts in how military experience was valued and utilized across American society. The conference concluded with the announcement of the Sarah Chen Fellowship Program, which would provide full scholarships for military medical personnel pursuing advanced civilian medical training, along with guaranteed job placement in healthcare systems that had committed to supporting veteran career transitions. Dr. Chen, said Dr. Morrison, now serving as the National Civilian Medical Director for the Integration Initiative, this fellowship program ensures that your legacy will continue to benefit veterans and patients for generations to come. Sarah felt the familiar discomfort that came with personal recognition, but also the deeper satisfaction of knowing that systematic institutional change would continue to benefit people long after her individual contributions were forgotten. The fellowship program represented the kind of systematic support that could have transformed her own transition experience, and knowing that future veterans would have access to those resources filled her with profound gratitude. 10 years later, the graduation ceremony for the 10th class of the Sarah Chen Fellowship Program took place on a sunny afternoon in the gardens of the Military Medical Excellence Center, now expanded to include research facilities, training centers, and administrative offices that coordinated military medical integration programs across North America and Europe. Sarah, now in her early 50s, sat in the front row watching as 47 military medical personnel received advanced certifications and job placement guarantees from healthcare systems that competed for the opportunity to hire veterans with combat medical experience. The ceremony represented the full institutionalization of changes that had once seemed impossible. Dr. Emily Rodriguez, the nervous young Army physician who had been among the center's first graduates, now served as its director, having taken over from Sarah 2 years earlier when Sarah had transitioned to a role as senior advisor and research director emeritus. Emily's transformation from anxious veteran to confident leader reflected the broader changes that systematic institutional support could produce. 10 years ago, Emily said, addressing the graduating fellows, Dr. Chen stood in a VA cafeteria and was questioned about the legitimacy of her military service and medical credentials. Today you are graduating from programs that actively seek out and reward military medical experience because we have proven that your expertise saves lives and improves healthcare delivery. Marcus Rodriguez, now in his early 40s and serving as a senior policy advisor to the Department of Veterans Affairs, stood up to address the graduates. His left leg still bore the scars of combat surgery, but his career had evolved to encompass veteran advocacy, policy development, and institutional change management that extended far beyond healthcare. When I defended Dr. Chen in that cafeteria, Marcus said, I was angry about institutional bias and frustrated with civilian assumptions about military experience. Today, I'm here to tell you that systematic change is possible, that your service will be recognized and valued, and that you have the support systems necessary to succeed in whatever career path you choose. The graduation ceremony concluded with the presentation of the annual Sarah Chen Award for Excellence in Military Medical Integration, given to a civilian healthcare institution that had demonstrated exceptional commitment to recruiting, supporting, and advancing military medical personnel. This year's recipient was a rural hospital network in Montana that had become a national model for utilizing military medical expertise to improve healthcare access in underserved communities. As the ceremony concluded and graduates mingled with family members, colleagues, and potential employers, Sarah walked through the gardens reflecting on the journey that had brought her from combat surgery in Afghanistan to this moment of institutional celebration and systematic change. The path had been marked by confrontation, bias, and struggle, but it had led to outcomes that had improved the lives of thousands of veterans and millions of patients who had received better medical care because military expertise was finally being recognized and utilized effectively. Dr. Foster, now in her 60s and serving as the center's senior research advisor, joined Sarah as she walked through the gardens. Sarah, she said, do you ever think about how different things might have been if Marcus hadn't been in that cafeteria that day? Sarah considered the question, thinking about the role that chance encounters and individual courage had played in creating systematic institutional change. I think the confrontation was inevitable, she said. Too many veterans were struggling with institutional bias for the system to continue unchanged. Marcus and I just happened to be the catalysts for changes that needed to happen. The conversation was interrupted by the approach of Dr. James Park, Dr. Lisa Park's grandson, who was beginning his military medical career with the confidence that came from knowing that his service would be recognized and valued when he eventually transitioned to civilian practice. His presence represented the generational change that had transformed military medical careers from struggles for recognition to pathways for professional advancement. Dr. Chen, James said, I wanted to thank you for creating the opportunities that my generation takes for granted. My grandmother told me stories about the discrimination she faced, and it's hard to imagine that world when I see how military medical experience is valued today. Sarah felt the profound satisfaction that came from witnessing generational change that had transformed institutional cultures. James would never have to defend the legitimacy of his military medical experience or downplay his service to fit into civilian healthcare settings. The systematic changes that had grown out of her individual confrontation with bias had created a world where military service was recognized as an asset rather than something to be overcome. As the afternoon wound down and graduates departed to begin their civilian medical careers, Sarah remained in the gardens, looking up at the bronze plaque that had been installed near the center's entrance. The plaque bore a simple inscription, "Where silence is never forgotten." The words reflected the center's commitment to ensuring that military service and sacrifice would never again be overlooked or undervalued in civilian professional settings. The phrase had become the unofficial motto of the military medical integration movement, appearing on center publications, fellowship materials, and institutional partnerships around the world. Marcus approached Sarah as she stood reading the plaque, his presence carrying the comfortable familiarity of someone who had shared the journey from initial confrontation to systematic institutional change. "Ma'am," he said, using the formal address that had never quite disappeared despite years of civilian partnership. "Any regrets about how things turned out?" Sarah considered the question, thinking about the alternative paths her life might have taken if that confrontation in the VA cafeteria had never occurred. She might have continued struggling with institutional bias, might have accepted that military experience would always be undervalued in civilian settings, might have spent her career defending her credentials rather than advancing medical knowledge. "No regrets," she said, her voice carrying the certainty that came from having seen systematic change produce measurable improvements in people's lives. "The struggle was worth it for the generations of veterans who will never have to experience what we experienced." As the sun set behind the Military Medical Excellence Center, casting long shadows across the gardens where hundreds of veterans had celebrated successful transitions to civilian medical careers, Sarah felt a deep satisfaction that came from knowing that individual courage and institutional persistence could create lasting change. The center would continue its work long after she was gone, supporting veterans, advancing medical knowledge, and ensuring that military service was recognized and valued in civilian professional settings. The systematic changes that had grown out of a single confrontation over an ID verification had become permanent features of American healthcare, improving outcomes for both veterans and the patients they served. The fluorescent lights of that VA cafeteria had been replaced by the warm glow of institutional recognition, professional respect, and systematic support for military experience. And in that transformation, thousands of veterans had found not just employment, but meaningful careers that utilized their skills, honored their service, and contributed to the broader mission of healing that had always been at the heart of military medicine. Subscribe to Stories of Service, where silence is never forgotten.